Welcome to this talk on head injuries. But before we start talking about head injuries, I want to talk about something very important. Patients with head injuries often have reduced levels of consciousness and therefore can't tell you if they have a pain in their neck or in their back. And it's very important that if a patient has got a reduced level of consciousness and a head injury, we assume that they have a spinal cord injury until proved otherwise. And particularly we're concerned about injuries to the cervical spinal column, the first 7 vertebrae, with the spinal cord running through. Now the spinal cord is a bit like this piece of paper. It's in between, it's going through the cervical vertebrae. And that's fine as long as the cervical vertebrae are intact. But what can sometimes happen if a patient's been traumatised, there can be a fracture to the cervical vertebrae. And that means that there is an instability. Now actually that doesn't matter too much as long as we maintain good alignment. But if someone comes along and moves the head and the body independently, then because the neck is now loose, this is completely useless now, isn't it? The spinal cord can be completely transected. So a fracture of the cervical vertebrae can be displaced, damaging the spinal cord. And of course the importance of this can't be overstated. That means if there's a complete transverse lesion of the spinal cord, the patient will never feel anything below the level of that lesion ever again. They will never be able to move anything below the level of that lesion ever again. That's why we have to be very careful to look after the cervical spinal cord. And we maintain alignment of the head and the neck by neck braces, blocks on the side of the head, and taping the head to the trolley or the transfer trolley or whatever the patient happens to be on to maintain stability. And we don't take them off until we've taken x-rays where we can see from C1 all the way down to C7 and T1 to make sure the cervical vertebrae are intact. Let's have a look at these in some more anatomical detail now. So here we see the occipital bone of the skull and the first cervical vertebrae. And in this model the nerves are in yellow, nervous tissue is in yellow. So the first cervical vertebrae is sometimes called the atlas and the second one the axis. But that's C1, that's C2, 3, 4, 5, 6, and then the 7th cervical vertebrae is this more prominent one here that you can feel when someone's head is bending forward from the back. So 1, 2, 3, 4, 5, 6, 7. And then we're on to the thoracic vertebrae after that. So that is the first thoracic vertebrae there. So that's T1, T2, 3, 4, 5, 6, 7, 8, 9, 10, 11, 12. That means this must be the first lumbar vertebrae, which is L1, L2, L3, L4, and then down to L5. And we can see that there's nerve roots coming out between the vertebrae. 31 pairs of spinal nerves, of course, altogether. So this is the first cervical nerve root. C1, 2, 3, 4, 5, 6, 7 and 8. Now note that there are 7 cervical vertebrae but 8 cervical nerves because the first one is above. 1, 2, 3, 4, 5, 6, 7, 8. Then this means these are the thoracic nerves. 1, 2, 3, 4, 5, 6, 7, 8, 9, 10, 11 and 12. And then the lumbar ones 1, 2, 3, 4 and 5. But thinking about the cervical spinal cord, we can see the massive importance of this here, because if these vertebrae are broken and they can displace and tear the very delicate neuronal tissue in the spinal cord. And if the cervical cord is broken, the nerve impulses can't get down, carrying motor impulses, the sensory impulses can't get up, and the patient can't feel or move the entire body below that level, with of course devastating consequences. So please do look after your patients' spinal cords, particularly their cervical spinal cords. Let's think about some background in trauma now before we focus in really on head injuries. Now, we've mentioned about the importance of the cervical spine and assessing the integrity of the cervical vertebrae from C1 through to C7, including T1, to make sure that is intact and there's not going to be any secondary damage to the cervical spinal cord. Now, what about priorities? Well, paramedics and A&E people often talk about the priority of ACBC. So we're all familiar with the priority of ABC, airway, breathing and circulation. But so important is good management of the cervical vertebrae in traumatology that ACBC is often spoken about. And this gives us the first priority as being airway, then the second priority as being the cervical spine. So it's airway, cervical spine, breathing, and then circulation. That just shows how important it is not to damage the patient's cervical spinal cord if there's any fracture which could possibly be resulting in instability in that part of the body. And to take account of this, we always practice full precautions. There's 3 components. There's the neck brace, which must be properly fitted. There's the blocks on the side of the head, and there's the taping the head down onto the trolley or onto the spinal board to make sure that there is complete alignment of the head and the body, that there's no disalignment that could possibly dislodge broken or disrupted cervical vertebrae. Now, why is it so important to think about head injuries? Well, clearly head injuries are a life-threatening injury, but they're also a very common injury. It's the most common single organ which is damaged, or head injuries are the most common part of the body which are affected in trauma, especially in young people. And in many countries, in Western countries, remember, trauma and accidents remains the most common cause of death in young people. And of course, brain cells do not maintain powers of mitosis throughout life. Now, there is some cell division going on inside brains, but it's very limited. And with the cerebral cortex on the outside, in the adult, there is essentially no cell division at all, no ongoing mitosis. This means if there is any injury to the brain cannot regenerate, and that damaged area of the brain is permanently damaged. And of course, if this happens in a young person, then they have that degree of disability with them for the rest of their lives. Now, the patient's admitted, we want to gain information about what caused the accident, the type of trauma, because the sort of accident, the history of the accident can tell us what injuries the patient is likely to have sustained. And also, it's very important to know if the patient's been knocked out, because if the patient's been knocked out, there's probably been a greater amount of trauma to the head. And unfortunately, alcohol is often involved in head injuries. Some surveys have shown that over 30% of patients who sustain injuries have been using alcohol prior to the injury. Sometimes even more than that, it depends on the particular survey. But it's also important for us clinically, because if there's drugs or alcohol involved, that can alter the level of consciousness of the patient, and of course that can change our clinical observations. So we need to know about these things. And then when someone's first admitted, we do the primary survey, airway, breathing and circulation, but remember we're taking into account the cervical spine, ACBC. Now, in A&E departments, having ascertained that the airway, breathing, circulation and cervical spine are currently being looked after, it's then possible to go on to primary resuscitation. And this involves giving fluids and giving oxygen.